Hi, everyone. Good afternoon. I almost said morning. Good afternoon, and welcome to the Les Turner ALS Foundation's May Learning Series, and happy ALS Awareness Month. I just want to remind you as you guys are joining, remember you're muted and you're off camera, so just sit back and relax. The program should last about an hour, and we will have our Q&A once the content portion has ended. You will notice to the right of your screen that there will be like a question box, so feel free to drop any questions in real time, and then we'll save those for the question and answer portion. The other thing that I briefly mentioned, but just want to remind you as well, is that it is being recorded. So for whatever reason, if you have to run or jump off, or if you knew somebody who registered but wasn't able to make it today, it is being recorded and it should be up on our website in about a day or two. And again, feel free to reach out to me if you need the link on where to find that. In the meantime, I'm Anne-Marie Doyle. I'm the Community Education Manager at the Les Turner ALS Foundation. Again, thank you for joining. And let me tell you a little bit more about the foundation. First of all, we just want to thank our sponsors. The ALS Learning Series is made possible because of a donation from the Gilbert and Jacqueline Fern Foundation and our industry partners, Mitsubishi Tanabe Pharma America. And who are we? At the Les Turner ALS Foundation, we are leaders in comprehensive personalized ALS care and research. Our support service team is comprised of knowledgeable and compassionate nurses, social workers, and therapists who have many years of experience helping people and families affected by ALS. We offer a variety of services like care visits by our ALS support care coordinators, need-based grants, and connecting people with community resources. At the Los Angeles ALS Clinic at the Les Turner ALS Center at Northwestern Medicine, we offer access to enrollment in clinical trials and a multidisciplinary team that aids in providing comprehensive support. If you're looking for in-depth information about ALS symptoms or are just interested in browsing our past ALS learning series, please visit our website. Those our guides and our past ALS learning series can be found on the website. And I can also drop that information in the chat. And I also want to talk about my ALS decision tools. So we know that making decisions about ALS care can be really overwhelming. But again, we're here to help. The Les Turner ALS Foundation developed my ALS decision tool to help you learn about your options. And you may be familiar with our breathing and our nutrition support modules, but as of last Monday, we have a brand new module on genetic testing, and I can send the link in the chat again if anybody is interested in looking at that. Also, if you have used our decision tools or any of our education materials, I'll also drop in the chat a link to a SurveyMonkey because we're always looking for feedback on what we provide. Now, okie dokie, hold on a second. There we go. Okay, so now what we've all been waiting for. I am honored to introduce you to Jennifer Rogenbach, a genetic counselor at The Ohio State University Wexner Medical Center. Jennifer is a genetic counselor and an associate professor at The Ohio State University, where she studies genetic testing and counseling outcomes and best practices in ALS clinical genetics. So give me one moment. Let me stop sharing my screen and let me give the reins over to Jennifer. Welcome, Jennifer.
Thank you so much. And I am just looking at my screen, figuring out how to share. Let's see. Yes, I am not seeing how to share. Oh,
Okay.
yes. Thank you.
Okay.
And one more step, and I think I'll have it. Can everyone see my title slide?
I do not see it, but I'm also happy to take over the reins and progress your slides.
Okay, that would be fine.
Oh, there you go. Now I see them. Sorry, I think there was just a delay in sharing your screen.
Okay. All right. Well, thank you for
There you
that. Thank you for that introduction. Now I'm not seeing my screen, so let me see if I can change this again. All right.
And if you, oh, there you go.
Okay.
That
Well,
looks good.
okay, but the trouble is I can't see my slides currently, so we need to fix
Okay.
that.
Do you want, why don't I, thank you everyone for being so patient. Why don't I share my screen and I can progress your slides for you. That's no problem at all.
We actually did do a dry run of this, so apologies for the difficulties.
Okie dokie. Can
right.
everybody see this okay?
Thanks so much for your patience while we figure that out. But I'm Jennifer Rogenbach, as mentioned, and I'm happy to be here today to tell you about our project to develop evidence-based consensus guidelines for genetic counseling and testing in ALS. And when I say we, this was definitely a group project with my collaborators, Dr. Brita Eubank from Mount Royal University in Canada, Dr. Steve Cole from Ohio State, and also Dr. Matt Harms from Columbia. Next slide. These are my disclosures. Next slide. So on our agenda today, we'll first talk about the possible benefits of genetic testing for persons with ALS and talk about why someone with ALS would want to even think about having genetic testing. Then we'll spend a few minutes doing some background overview on ALS genetics, and then I'll walk you through the recommendations that we developed for professionals who are seeing persons with ALS who may want to offer genetic testing. And we did intend that these guidelines would be for all professionals, whether that's a neurologist, a genetic counselor, a nurse practitioner, whoever might be providing care to a person with ALS. Next slide. So why are we having this discussion? Why should someone with ALS consider genetic counseling and genetic testing? And this is a question that I commonly get at the time of diagnosis in our ALS clinic. Does ALS run in the family? Is it genetic? And the answer is that in some cases, ALS can be genetic, and genetic testing is a tool that we have to investigate the cause. And thereby, we can sometimes clarify the disease risks to relatives, as well as enable pre-symptomatic testing for family members, or even pre-implantation genetic testing to enable individuals with genetic forms of ALS or who are carriers for genetic forms of ALS to empower their own reproductive decisions. Also, another important reason to consider genetic testing is that it may open the door to participation in gene-targeted natural history studies or clinical trials, and as of 2 weeks ago, approved therapies. So as most of you know, we did have the first FDA approval for a gene-targeted therapy in ALS 2 weeks ago. So it's exciting times, and it's a good time to be considering how we can best provide genetic counseling and testing to persons with ALS. Next slide. So another question, often the next question that commonly comes up in clinic is, what's the chance that I would test positive for an ALS gene or genetic variant? And the answer to that question really depends on the individual's family history. And for persons with no known family history of ALS, the chance that they would test positive for an ALS genetic variant is about 12%. However, if you do have a family history of ALS, particularly in a close relative like a parent, a sibling, a child, or an aunt or uncle or grandparent, the chance that we would find a genetic cause is much higher. It's actually about 65%. And of course, having a positive genetic finding has significant implications for family members and their risk to develop ALS. And as mentioned, there's the potential for our treatment modalities to be impacted by genetic testing results. Next slide. So when thinking again about the likelihood of a genetic cause for ALS, the literature has historically divided persons with ALS into two types based on their family history. And I thought I would take a moment to define this because so much of the literature and the risk information we discuss hinges on whether you have a family history or not. So sporadic ALS means that there's no known family history of ALS. And I've put sporadic in quotation marks because, of course, just because there's no family history of ALS doesn't mean that there's no possibility of a genetic cause. However, if we look at people with quote unquote sporadic ALS as a group, we see that they have a later age of onset than people with familial or hereditary ALS. And again, we're able to find a genetic cause in people with quote unquote sporadic ALS about 12% of the time. Next slide. In contrast, familial ALS is passed on in families, and we can see multiple individuals in subsequent generations affected with ALS. And familial ALS tends to be a dominant condition or a dominant predisposition. And I'll discuss what I mean by predisposition a bit later. But people with familial ALS often have an earlier onset age on average in terms of when those symptoms might begin. Also, people with familial ALS may have other persons in their family who have other neurologic conditions, specifically dementia. So there's a specific kind of dementia called frontotemporal dementia, or FTD, that is known to co-occur in either persons who actually have ALS or their family members. So the presence of FTD can be a marker of familial ALS. And there's more than 30 different genes that have been implicated in ALS, and this number continues to grow. Interestingly, however, the penetrance of these genes is variable. And that means that not all gene carriers will necessarily develop ALS or dementia. And this is something that is less well understood, I find, by persons with ALS and their families. And it's an important limitation for us to remember. And again, for persons with familial ALS, we're able to identify an underlying genetic cause in about 2/3 of the cases. Next slide. So how do you know if you have quote unquote sporadic ALS or familial ALS? If there's no known family history of ALS in your particular family, we would consider you to have a quote unquote sporadic ALS. Really, the better name for that would be idiopathic, which is the technical name for we don't know the cause. But since most people don't know that term, we tend to still use sporadic, even though that term has problems. But nonetheless, most people with ALS don't have a family history, so they fall into this quote unquote sporadic category. However, if you do have a blood relative who's had ALS or frontotemporal dementia, we might consider that, or do consider that, to be familial ALS. When you're trying to gather information about your own family, ask relatives about if they know anyone who's had ALS, motor neuron disease, dementia, Alzheimer's. Technically, Alzheimer's is not related to ALS, but sometimes people with FTD can be misdiagnosed as Alzheimer's. It's also important to ask about other neurologic conditions such as Parkinson's disease and psychiatric conditions like suicide and schizophrenia. And you can discuss these things with your neurologist or genetic counselor to try and get a feel for if they could be indicators of an increased chance for having an ALS variant. Next slide. So as we go through and talk about genetic testing options and the guidelines that we created, I just wanted to remind everyone that genetic testing is a personal choice. And even though it's a technology that we have available and there's a lot of excitement around it right now, part of the importance of offering ALS genetic testing is emphasizing that it is a choice. And just to, again, review some of the reasons to consider testing, we might be able to identify a cause. In some cases, we can refine the ALS prognosis in terms of rate of progression and life expectancy in some cases. I mentioned that having a genetic diagnosis could open the door to research or clinical trial participation, clarify ALS risks for family members, and in some cases, open the door to a specific gene-targeted therapy, as in the case of the recently approved therapy for SOD1-related ALS. However, there is the flip side of the coin that I don't want to ignore, in that some people may choose not to seek genetic testing. For many persons, genetic testing will not give an answer as to the cause. And even if we do find a specific genetic change, it might not enable us to be more specific about the ALS prognosis. In some cases, genetic testing can be costly. Right now, we do have a lot of free genetic testing options, but we don't know if those free testing programs will be available forever. Also, and this is a big one, many persons with ALS are concerned about burdening their family members with the knowledge of genetic risk. So this is something that I discuss with families when they're thinking about having genetic testing. And everyone has their own unique circumstances that they bring to this decision. Next slide. So just to get into a little bit more detail about ALS genetics, I've listed here the 4 most common ALS genes that we see in populations of European descent. And this first gene has a weird name, C9orf72. This gene is simply named for the location on chromosome 9 where it sits, but it is by far the most common genetic cause of ALS in North America and all populations of European descent. And as I mentioned, this gene can cause not only ALS, but also FTD. And there's some evidence that it may increase the risk for a variety of psychiatric conditions as well. And importantly, not all gene carriers will develop ALS or FTD. And if you look at the list of genes, you'll see that's actually true for all of these genes. Certain genetic variants might be more penetrant than others, but in all cases, there are examples of gene carriers who live to be an old age without developing ALS. And that means that we can't be certain about an individual's risk to develop ALS when they have one of these genes. But I just wanted to again point out that C9 is not the only gene that's associated with FTD. There's some other genes that are also associated with FTD. SOD1 is an exception. People with SOD1 related ALS do not develop dementia as part of that condition. So SOD1 is kind of the exception in that way. Now, of course, there are many, many other ALS genes. I've simply listed these here because these are the most common and have been replicated in multiple cohorts in many different populations around the world. Next slide. So I'm going to talk a little bit more about this C9 gene because it is so common in the United States, certainly in the Midwest. And it is, as I mentioned, the most common known genetic cause of ALS and FTD, and the combined ALS-FTD condition. And this gene is autosomal dominant, which means if you have it yourself, there's a 50% chance that it would be passed on each time you have a child. However, that's not a guarantee that that child would necessarily develop ALS or FTD. They're certainly at increased risk to develop one or both of those conditions, but it's also possible to live a very long life and not get any of them. And the specific genetic change that occurs in this gene is a unique repeat of the genetic code that we call a hexanucleotide repeat expansion. And that's a mouthful, so in the field, we all just call this the expansion. And what we mean by that is a portion of the genetic code that's repeated over and over again. And the cutoff that most laboratories use for what is an abnormal and disease-causing expansion is 30 repeats. But different labs use different cutoffs, and this is one of the challenging things about this gene is that there's different testing technologies that can have different abilities to detect expansions. And this is one of the things that we addressed in our guidelines that I will discuss. And it's quite technical, so I just wanted everyone to have a little bit of background. But when we get clinical reports back, they typically will just say the expansion is present or not. And the reports usually don't tell us how large the expansion is. But right now, that doesn't matter because there's no clinical correlation that we know of between the expansion size and any particular features of ALS. Next slide. So this gene has an interesting history, and or I should say this expansion has an interesting history, and it appears that it arose relatively recently in human history in Scandinavia only about 1500 years ago. So this is pretty unusual for a genetic condition. And studies have been done that seem to indicate that this expansion originated in Scandinavia and was spread throughout Europe along the routes of the Vikings. So we see higher incidences of the C9 expansion in Northern Europe and in coastal Europe and the islands of the Mediterranean, which were frequent Viking destinations. So this is a little interesting history, and this seems to account for why C9 is so common in Europeans and very rare in non-European populations. Next slide. And that is an important limitation of ALS research, is that most of it has focused on studying persons of European descent. And we know that the genetic profile of ALS is quite different in different geographical areas. As indicated in the map here, C9 is the most common gene in Europe and North America, but in Asia, the SOD1 gene or the SOD1 gene is the most common cause. So this is a limitation when it comes to our knowledge, because much of the risks that we commonly quote are based on the study of European individuals, and that information is not necessarily transferable to other populations. So I just wanted to point that out as an important limitation. If your ancestry traces to parts of the world other than Europe, we know less about the genetics of ALS, and our testing is not as good, our detection rate is not as good. Next slide. So you can go ahead and click on the next couple of bullets so I can talk about all of these trials at once. This figure to the right shows the history of gene discovery in ALS, starting with SOD1 gene way back in the 1990s. And these red arrows indicate genes for which there are active clinical trials right now. And actually, this is a little bit out of date because the VALOR study is completed, and that is the antisense oligonucleotide for SOD1 that was recently approved by the FDA. There is now a pre-symptomatic arm of this study called ATLAS, and if you are a healthy carrier of a harmful SOD1 gene, you might be a candidate for this trial, and it's pretty exciting because they are starting to give that treatment to people before the onset of clinical symptoms. So it's super exciting. And I wanted to show this just to emphasize that this is a very active area of research in terms of the race to find gene-targeted treatments for the hereditary forms of ALS. And we anticipate that more trials and ultimately more approved therapies will will come. Next slide. So despite the advent of FDA-approved therapies for ALS, and despite high patient interest in genetic testing, there are no actual guidelines yet that tell us how to offer genetic testing to persons with ALS and what this testing should consist of. And the American Academy of Neurology has an ALS management document that provides neurologists and other professionals with guidance about how to take care of persons with ALS. And this document actually does not even mention genetic testing at all. And it was recently reaffirmed in February of this year, still with no mention of genetic testing. So what that means is that the testing the testing practices are inconsistent, and we know this from surveying neurologists and other providers. We know that some patients with ALS are getting offered testing and some not. And in addition to the testing being inconsistent, there's also evidence that the information that patients are offered before and after testing is inconsistent and in some cases lacking. And as I mentioned, there are also some issues with respect to the technical aspects of testing, with different labs having different cutoffs and different practices when it comes to reporting specific genetic variants. So these are all challenges that sort of came to a head over the past couple of years, and these challenges really led us to try and devise guidance for the community to offer genetic testing in a consistent and a quality way. Next slide. And with these challenges in mind, my colleagues and I actually came up with a proposal and took that to the ALS Association to develop evidence-based consensus guidelines to really provide professionals with guidance as to what genetic testing should be offered to whom, and also what information should be given to patients before and after testing. And our hope was to improve and standardize the genetic counseling and testing practice for any person who happens to be caring for a person with ALS. So as mentioned, this is not just neurologists necessarily, it could be genetic counselors, nurse practitioners, or really anyone who's providing ALS care. The secondary goal, we hope to help characterize the ALS population and really understand which genetic forms are most common and which genetic variants are most common in different ALS populations. So we followed a very systematic approach in devising these guidelines, and I'll spare you most of the gory details, but the highlights are that number one, we define the clinical questions of what information do providers need when they're considering offering genetic evaluation to persons with ALS. Then we performed a rapid review of the literature according to a standardized process called PRISMA. And then we created recommendations that really were answers to each of the clinical questions that we had come up with. So each core question that we asked ended up with an answer that was the basis for our recommendations. Then we assessed the evidence base for each recommendation by combining two quality metrics to really weigh how quality the evidence was, and therefore how strong of a recommendation we can make based on that evidence. Then, and this was the fun part of the process, we recruited an expert panel, and we gathered neurologists who are academic neurologists, community neurologists. We included some patients with ALS, as well as advocacy representatives, and we convened this expert panel, and we had everyone vote on each recommendation until we received 80% consensus on each recommendation. And if a given recommendation did not reach 80% consensus, we did another round of voting to refine the recommendation. Next slide. And for those of you that are interested, this process is known as a modified Delphi process. And I'll tell you a little bit about kind of the final process. In round one, we had 45 of our recommendations, and actually 44 received 80% consensus on the first round, and there was only one recommendation that failed to reach consensus. And this recommendation stated that all persons with ALS of European descent should be offered the C9 test as the first genetic test. And this one fell just shy of reaching consensus, and we revised it based on feedback. And feedback from the group raised concerns such as, how do you define European ancestry? This breaks down the testing into multiple steps, and that takes more time. And we might only have one chance to offer genetic testing. So based on that feedback, we revised that testing recommendation to all persons with ALS should be offered testing with an ALS gene panel that includes C9. So what this basically means is that we should offer comprehensive genetic testing in one step for all the ALS genes that are considered to be proven causes of ALS. And we convened this final Zoom conference, and as you can see, there's a lot of different people who are participating in that call. I think I forgot to mention genetic counselors as important participants in that process, and our genetic counselor were actually among the most vocal in terms of providing feedback and additional guidance to the recommendations. Next slide. So with that, I'll walk you through quickly what the recommendations are. And I will go through this pretty rapidly, but please look for our upcoming publication, which will not only provide more detail about the recommendations, but also review the evidence and also the strength of each recommendation, which I'm not going to present today. Again, we have 3 realms that the recommendations sort of fall into. One is clinical testing, one is lab guidelines, and one is genetic counseling guidelines. Next slide. So as far as the clinical testing, this means what testing should be offered. And we recommend that all persons with ALS should be offered genetic testing with an ALS gene panel that includes, at a minimum, C9, SOD1, BUS, and TARDBP. Also, any other gene for which the FDA approves a targeted therapy. Also, genes rated as strongly or definitively associated with ALS by the ClinGen Committee. And the ClinGen Committee is an NIH-funded effort to basically curate disease-gene relationships. So this committee helps us really understand what counts as an ALS gene, and that's a more complicated topic than you might think. But basically, we're recommending that all persons with ALS get comprehensive testing in one step. Next slide. The lab guidelines, again, are fairly technical, but I know there are some health professionals in the audience today. But C9 testing can be obtained on non-CNS tissue. In other words, it's fine to do C9 testing on blood. We need a method with high sensitivity and specificity for those expanded alleles. That can be Southern blot, repeat primed PCR, dual mode PCR, or expansion hunter on whole genome data. We also need methods with a high sensitivity and specificity for non-expanded alleles, so those normal C9 alleles. So that can include fragment size analysis, alone or in dual mode PCR, or expansion hunter. C9 testing reports, and this is reports that are issued by the testing laboratory, should clearly outline the maximum number of repeats that are detectable with that assay. It's also important to specify the sizes of non-expanded alleles. And so it's important for the lab to highlight the clinical uncertainty of C9 expansions that are considered to be intermediate or uncertain. So if there's, in the rare case where there's a gray zone expansion, that needs to be clearly listed on the report. Next slide. Non-C9 testing should utilize panel, exome, or genome approaches rather than sequential gene testing. In the old days, we would test one gene at a time, and this was very time-consuming and expensive, but we just emphasize that testing should be panel and include C9 and all those other genes at once. And it's also important that test reports differentiate between causal genes and those with preliminary evidence. And that is a problem with clinical genetic testing, is that labs get in this kind of like panel inflation race, and they want to have the biggest, most extensive genetic test for ALS, but that's not necessarily a good thing if they're including genes that are not proven to cause ALS. It's also important that labs acknowledge if there's gaps in the coverage of their genetic testing. Next slide. So for the genetic counseling guidelines, the purpose of this guidance is to really convey to clinicians what information they should be giving to persons before and after testing. And that includes understanding the patient's individual clinical and family history circumstances. So remember before I talked about familial ALS and sporadic ALS. In order to know if a person has a family history of ALS or not, we need to ask a lot of questions. And we need to ask, is there motor neuron disease of any kind? Is there anyone with frontotemporal dementia or other dementias? Are there any movement disorders such as Huntington's or Parkinson's disease? Is there anyone with psychiatric disease? It's also important to share with persons with ALS about the different genetic causes of ALS. It's not just one gene that can cause ALS, and also how these genes run in the family. Most, as I mentioned, are dominant, so that means that parents can pass it on to children, typically with a 50% risk. But the penetrance can vary, and that means that the likelihood of developing disease if a gene is inherited. And for many ALS variants, just because you inherit that variant does not guarantee that you will get ALS or frontotemporal dementia. Next slide. Pretest counseling should also help individuals understand their personal risk for having a genetic cause for their ALS and for finding a positive result on testing, as well as what the recurrence risk is for relatives. And that's a common question that people have. What's the chance that my child could have ALS or my grandchild? And the best, most informed answer to those questions includes, genetic testing, which of course is a choice, but we can be more specific if we have genetic data. It's also important to help persons with ALS prepare for the implications of results for themselves and their family members, whether that's personally, psychologically, or economically. And this is all information that should be touched on before the test is sent. It's also important that everyone understand that there's a variety of possible outcomes with genetic testing, and that includes positive, negative, or uncertain test outcomes. And I'll talk about that in a moment. And also everyone needs to know that our testing has limitations and isn't perfect, and we don't always find a genetic cause in familial ALS, for example. Next slide. So in summary, our consensus-based evidence guidelines recommend that we should provide comprehensive ALS genetic testing to all persons with ALS, whether or not they have a family history, and no matter what their age of onset is. And testing labs should use specific methods and reporting for C9 and other genes. And persons with ALS should be provided with education and genetic risk assessment before and after testing. Next slide. So just to bring this back around to the individual with ALS, if you do have genetic testing, I just wanted to kind of share what's the key information that you should know about your test. So I've done a bulleted list here. Any person should know what genes were tested and was there a genetic variant identified. And genetic variants are technical, but it's important to document that information. We need to know the gene name, the DNA change, and the protein change. That's all information that's on the report. So ideally, you get a copy of your test report. Then if a variant was found, what is the interpretation of that variant? That means what is the expected clinical significance? Is it harmful, pathogenic, likely harmful, or likely pathogenic, or uncertain? Uncertain means that a genetic variant was found, but we don't know if it causes ALS or not. Also, is further genetic testing recommended? And this is something that may or may not be spelled out in the test, but this is something that you can talk to your doctor or genetic counselor about. And sometimes there is information in the fine print about next steps. And the bottom line is the overall result considered positive, negative, or uncertain. And this would seem to be straightforward, but it can actually be complicated. And that's why you really need to understand and ask questions about your report. I consider a positive result to be a genetic finding that accounts or explains for a person's ALS. There can be other positive results, however, that don't explain someone's ALS. For example, Tay-Sachs disease is considered to be an ALS mimic when it occurs in the late onset form. So some ALS panels include the gene for Tay-Sachs, and that's a recessive condition, and it's possible to just be a carrier for Tay-Sachs. And the test report might say positive, but it's positive for a recessive gene that is not causing that person's ALS. So that's just one example of, even though the report might say positive, it's not an explanation for your ALS. So there's a lot of complexities, and it's important to review your results with your doctor or genetic counselor or a knowledgeable person, and really, drill down, does this give me an answer about why I developed ALS, and what does this mean for my family members? Next slide. So again, if you have questions, talk to your doctor or genetic counselor. Ask what the result means for you. Does it explain your ALS? What does it mean for your family members? Are they at increased risk? Can they have pre-symptomatic testing? Keep a copy of the result in a safe place, because that result might be needed down the line if family members were to have genetic testing or want to have pre-implantation genetic diagnosis. It's also really important to know that test results, the interpretation of variants can change over time, and a variant that we consider to be benign or harmless today could be considered harmful once we get more data, and vice versa. Actually, the vice versa is more common. Also, testing options may evolve over time. We're likely to continue finding new ALS genes and have better, more accurate tests in the future. So particularly if you have familial ALS and have had a negative result, you might ask about retesting at least once a year, especially if you hear about a new gene being discovered or a new technology being developed. Next slide. So I mentioned that there's still challenges and limitations despite our guidelines, and that many cases of familial ALS remain unsolved with currently available tests, and that's up to 1/3 of cases. We have a lack of data on ALS genetics and testing outcomes in non-European individuals, and that means that our genetic counseling is often less specific for those populations. C9 tests don't use consistent cutoffs or provide sizes of expansions, and we're trying to change that, some of those inconsistencies with our guidelines, but currently many labs are not providing that information on their test reports. Uncertain test results are common, and that means there was a genetic variant found, but we're not sure whether it causes ALS or any condition. Also, we don't know the disease risks for many ALS variants, and that includes the common C9 expansion. So we know that C9 carriers certainly have a significant risk of ALS and FTD that gets higher as they age, but we don't have a precise figure for that risk, and that's a limitation that we have right now. These are all, we're all learning together. So it's no one's fault that we don't have all the answers, but we do need to be transparent that we don't have all the answers. Next slide. So I would like to acknowledge our nationwide cohort of experts that participated in our expert panel. And as mentioned, that includes academic neurologists, community neurologists, genetic counselors, persons with ALS, and we even had 1 or 2 healthy individuals who are carrying ALS variants too. And it was really a pleasure to work with this group. And they were very engaged and motivated, and we were able to get through this part of the process very quickly. Next slide. And I'd also like to acknowledge the ALS Association for funding this work, and our team at Ohio State who ran the REDCap system, and Josh Wright, who was our project intern. And with that, I hope that there is some time for questions.
Jennifer, thank you so much. I really, really appreciate that. That was a fantastic presentation. Let me just close this and pull my slides back up. So yes, we absolutely have time for questions. And I guess off the top of my head, I have a couple just kind of general questions. So Jennifer, if I am on the fence, or maybe I'm not sure if I want to pursue genetic testing, is it okay to just meet with a genetic counselor? You know, to meet with them and kind of talk through different options and different outcomes? Like, is that an okay step in this whole process?
Sure. And I think that is a misconception that people have, that just because they have an appointment with genetics or an appointment with a genetic counselor, that means they're going to get genetic testing, and that is not true. Certainly, genetic counselors are very non-directive and want to help people explore their own motivations for testing or not testing, and recognize that those motivations may change over time. And there might be an intermediate or kind of a halfway solution. And one thing that people in that situation can do is consider having DNA banking. And what that means is we store that individual's DNA in a safe place at a laboratory, and that will enable us to test it later. And that will basically, it's like having your DNA in the bank, literally, to come back to later to test. And that could be even after the affected person's death. And that is really powerful and can provide that it can empower family members to get that information, even if the person who's affected wasn't ready to do that. So that's one example of like a problem-solving approach that could be offered. And with this current environment of having recent FDA approval of a gene-targeted therapy, I think many people in the past who were hesitant to have genetic counseling will, kind of be reconsidering that decision. And it's fine to, ask to talk about it again. And just because you're asking the questions or coming in for a visit doesn't mean your blood's going to be drawn for testing. That is, part of what genetic counseling is that, respect for the autonomy of the individual and the right of that individual to make his or her own decision. And genetic counselors in particular are very aware and supportive of that.
That's great to know. That's great to know, because too, I think that's helpful to have out there, that just because you're meeting with a genetic counselor doesn't mean you have to get testing. Again, it's your choice. You get to decide if you want to get testing, who you share those results with, if you want to know those results, and kind of what you do with those results, right?
Yes.
Yeah. Kind of in the same vein, this just came in through the chat. If a person with a familial history of ALS provided a blood sample back in 1994, is it possible to find out if they had one of these new genetic variants now? Like I think you had mentioned some like reclassification of genes. Would that still be viable?
The original sample?
Mm-hmm.
It depends on how it would be stored, but generally not. Certainly commercial labs do not keep DNA around that long. And even research studies, most of them don't have approval to keep it for decades. Now that, there could be certain exceptions to that, but if the DNA is stored, if there's sufficient quality DNA stored in the right way, it's theoretically possible to go back and retest a decades-old sample. But it's not ideal. And I know that's hard because, I get this question a lot, people who may have had a deceased relative, and maybe that relative was only tested for SOD1, and now we know about all these other genes. So that's where that question comes up frequently. And you can always ask, particularly if it were a research study, is there DNA available? It's always worth asking, but getting those answers can be difficult. And then once we get the specimen, it may or may not be adequate to run the kinds of tests that are run today.
Okay. Kind of a more practice-related question. Do you have, what are your preferred labs or panels when doing genetic testing for ALS? And if a panel is negative, do you have ideas on of sensitivity of WGS or WES?
Yes. So
Okay.
a panel, as I mentioned, simply means we're testing a collection of genes that we specify in advance. And that's how most clinical genetic testing is done today, including ALS genetic testing. And there are at least 2 free genetic testing panels right now that are completely free to the patient and the institution and the provider. One is offered by Invitae, and it's called the ALS Identified Panel, and one is offered by Prevention. And I'm forgetting the name of that panel, but the Prevention panel is a little bit bigger. It includes the Ataxin-2 gene, which the Invitae panel does not, but they're both completely free. And the results come back in 4 to 6 weeks, and both labs are definitely high quality labs. They both offer genetic counselor support, both for their provider and the patient. So if you're a patient and want to talk to a genetic counselor and there's not one available at your center, you can call these labs and ask to speak to one. Same thing with a provider. There's other testing labs too that offer genetic testing, but those are the 2 ones that are free right now, and that certainly are being heavily used in practice for that reason. As far as whole genome and whole exome, that refers to situations in which we use our technology to test every coding gene for whole exome and every gene in the body for whole genome. So that is a method that is used in research to discover new genes. It's also quite heavily used in pediatric genetics. It's been less well studied for clinical use in ALS, and we actually don't know the answer to the question of, how sensitive is it to actually find a cause if a panel has failed to. My hunch is that it's a low. Our chance of getting an answer with whole genome or whole exome after a negative panel is low, but it's not 0, and it's certainly worth considering. And this is a test that can be clinically ordered, but it is more costly because you can imagine testing every gene in the body is something that takes a lot of computer power and a lot of person power, and therefore is quite expensive.
And
there might be a research protocol you could join, but research protocols may or may not share results back with the individual.
Yeah, I think that's a really good mention there. And because it seems, I don't want to misspeak, but like kind of outside standard of practice, that whole genome or exome sample is likely not covered by insurance. Like, would that be an out-of-pocket expense when you mean it could be costly?
Yeah, for many families it is. And just as an example, I think Invitae offers a patient pay exome, which I think is $1,250, so $1,250, and that's a lot, but it's actually a discount. It's a cut rate compared to what the actual cost of the panel is, and that's just an example of the lab is trying to make the test accessible for more people. But it hasn't been well studied in terms of what's the likelihood to actually find something from someone who's had a negative panel already.
And then again, another kind of practicing question that came in, and I do know that we have some professionals and possibly some newer genetic counselors, but this question came in, what is one thing you wished you knew early on when counseling asymptomatic patients?
Yeah, that's a great question, and certainly I was in that situation as a genetic counselor new to this area, and I would say I wish I clearly understood how poorly we understand penetrance. And penetrance, again, is the likelihood of developing disease when you have a harmful genetic variant, particularly for C9. If you read much of the literature, they will estimate the penetrance as 90% by age 80. And that is the number that I quoted for the first year or so that I was practicing as a genetic counselor. If I was seeing someone who tested positive for C9, I told them, according to the literature, the chance that you'll get ALS or FTD is 90% if you live to be age 80. But in my practice, in population studies done in Europe, we have observed a far lower penetrance, and actually population studies in Europe have suggested a penetrance of about 30%. Now, I do not use that number. I don't use any number in counseling families because I think it's wrong to use a number when we don't actually know. So that's a regret that I have, is that, I think I overestimated the penetrance, and that, those penetrance estimates are, there's an ascertainment bias because we were studying families with the most aggressive, most cases of ALS with the earliest onset. And that's not necessarily representative of the C9 alleles that are out there in the population that we might be finding now that we're offering testing universally. So that's probably the thing that I wish that I knew. However, I still don't have like the answer. I just think that we should be careful and acknowledge that we don't understand penetrance well. And this will become more critical as we start to think about treating people pre-symptomatically. We don't want to treat someone and with a treatment that may have a risk for someone who's never going to get ALS or FTD. So we might need to follow biomarkers and have some other ways of determining who is more likely to develop symptoms. So this is a new and controversial area, and I should note that I'm only offering my opinion on that. Other experts will have different opinions, and if you're a patient who's seeing multiple experts, you will likely hear different stories on this topic. So that's another challenging thing for patients, because it's disturbing to hear different things from different experts. But I think it's a reflection of the fast pace and incomplete knowledge that we're faced with right now.
Great, thank you. What about if I've had genetic testing before and maybe I got a variant of uncertain significance, how can I stay on top of these new gene variants? Do you have any advice on that? Or maybe if something was reclassified, like what's the best way to stay on top of that information?
Right. So some labs will automatically reclassify if they get new information, and they'll send the ordering provider an updated test report. So that's one way to be notified if a variant classification has changed. Now, all laboratories don't necessarily do that, so but that is one way. The most important thing is to keep a copy of the report, know what your variant is, like down to the most nitty-gritty detail. So you have to have the report, and then you can ask your provider or a genetic counselor, or even the lab itself. And you can call these labs, they all have customer service lines, and ask if that variant has been reclassified. So that takes a little bit of ambition, but it certainly can be done. And another way is to get the test again. And that obviously may have a cost to it, but will then include any interim genes that have been found since the original test was done, and potentially it will provide interpretation for a variant. And if a variant does not appear on that retest, the question would be, was it reclassified as benign? Is that why it's not listed? So there can be a lot of ins and outs of that, but again, a genetic counselor can help navigate those complicated situations. And the most important thing is to get a copy of the report.
Okay. And I think you kind of mentioned this. So the next question was just about like family members, where should they go to get tested? Do you think the first step again should be meeting with a genetic counselor to kind of talk through that, and then the genetic counselor can then help provide them with either an area to test or not test, or etc.?
Yes. So thank you for that question. I did not really address pre-symptomatic testing very much in my talk, but it is important. And this is one area where I feel that individuals who are considering pre-symptomatic testing ideally should see a genetic counselor. Genetic counselors are trained to consider the various aspects and personal and family and legal and ethical and insurance implications that may arise with pre-symptomatic testing. And genetic counselors can be found at nsgc.org. I think you dropped that into the chat. So
yep, it's in the chat.
Where you can enter your zip code and kind of get a list of genetic counselors in your area. So that is something that I encourage people to do. And again, just because you go talk to a genetic counselor doesn't mean that you have to get testing. There's a lot to think about, and we encourage people in that situation to take time.
Fantastic. Jennifer, thank you so much. And thank all of you for participating. Before we get going, our next ALS learning series will be June 19th. So please make note, this is a Monday. It's a new day. Typically we hold these on Thursday, so just be mindful. New day, Monday, June 19th, 2023 at 12 p.m. With Dr. Lisa Wolf, who's a pulmonologist. She'll be explaining tracheostomy, an invasive ventilation for people living with ALS. Again, thank all of you for your participation today. We really appreciate it. As you log off, you will get a survey. Please feel free to fill that out. I go through every single survey. Your feedback makes us better. It helps us produce better materials and better resources. So it is really helpful. And then again, you can visit us at lesturnerals.org. You can get our resources through lesturnerals.org/resources. And again, take a look in the chat. I dropped the NSGC, how to find a genetic counselor, links to our tool, our resources, our SurveyMonkey, our genetics page. So it's a host of resources in there. You can also follow us on Facebook, Twitter, Instagram, LinkedIn, and YouTube. Again, this will be recorded, and the link should be live on our website and YouTube channel probably within a day or two. Jennifer, I want to thank you so much for your time and expertise today. We really appreciate it. I hope everybody continues to have a great ALS Awareness Month. Please stay safe and healthy, and we will see you in June. Bye, everyone.